button right here, it'll pour on your face.
Yeah.
The back side.
They're really a setup for failure.
Yeah, not good. About to throw it away.
So I think I selected 5 cases to go through today, each with some good points, some stuff that I wanted to point out, some good questions in them. So the first one was a 90-year-old woman that fell backwards, hit her head outside of a physician's office, I believe, walking in to get her suprapubic catheter changed or something like that. Had a loss of consciousness. She was with her son, but he didn't see her fall because he was walking in front of her. She was out for a minute or so, and kind of some things that they documented. Confused as to her fall, did not remember falling, not on blood thinners, 2 to 3 centimeters right parietal laceration. She got moved to the cot, manual C-spine was held, palpated the back of the neck, no obvious injury there, denied any pain to her neck. So a couple questions that came up in my mind reading through this related to, because it seemed like the whole, about a third of the narrative documentation seemed to be saying, don't think there's a spinal injury. So do we need to worry about geriatric C-spine injuries? Are there any sort of clinical screening criteria that can be useful in geriatric C-spines? Are there any associated injuries that we need to worry about, and does immobilization help? So for a fall from standing, that causes about half of all C-spine fractures in patients over the age of 55. 20% of all fractures, of all C-spine fractures in general, are in patients over the age of 55. And a patient over 55 is twice as likely to fracture their C-spine from the same incident as somebody under the age of 55.
We're in trouble.
And interestingly, in patients under that age, almost all fractures are in C6 and C7, which is easy to palpate, easy to notice defects in, whereas in the geriatric population, they're almost all in C1 and C2, which is near impossible to palpate. And mortality, 1-year mortality after a cervical fracture is 40%. It's the highest of any fracture. A lot of research is done into hip fractures because they have a lot of high mortality, but this is almost twice that. So I think that it is important to worry about the cervical fracture, even for the fall from standing in the geriatric patient. There are clinical screening criteria that we use to assess for cervical fractures and whether or not any imaging needs to be done. 2 main ones, the Canadian C-spine rules and the nexus criteria. Age greater than 65 is an automatic exclusion criteria from the Canadian C-spine, so that's out. And then the nexus criteria, in one study looking at about 500 geriatric patients, it only had about 65% sensitivity, and that's not good enough for me. And 3%, I like this information, 3% of completely asymptomatic geriatric patients that fell from standing have a cervical spine fracture.
Does it matter if it's a forward fall or a rear fall?
No, any fall or a sideways fall. And they also include in this fall from standing anybody who's normally in a wheelchair and falls out of their wheelchair. So a fall from seated in a non-mobile patient. So clinical screening is pretty much useless. In the ED, I CT every single patient over the age of 65 that fell. Associated injuries, 20% of patients with a C-spine fracture have additional spinal fractures, and then 6% have some sort of intracranial hemorrhage or intracranial injury or calvario fracture. So
Go back 2 slides real quick.
2 slides?
Where it says they have no tenderness,
Yeah,
define tenderness. You mean me touching them and it doesn't hurt, or
Yeah.
them saying it doesn't hurt?
you touching them and it doesn't hurt. So that's the difference between these two. This 3% don't even complain about pain in their neck. Most of that 45% who have no tenderness at least complained of pain in their neck. So there was something to cue us off, but no pain when you touch it. And part of that is probably because it's so difficult to palpate C1 and C2.
So you only find that when you CT.
Yeah. So if we can't find out, then should we be having them in cervical collars? C-spine collars cause increased pain, they make it difficult for people to breathe, and they have been shown to increase delirium in elderly patients. That being said, patients who come into the ED without a C-spine collar in place get less evaluation of their cervical spine, which that's been studied pretty well. So I think it's still definitely the standard of care to use a C-collar in a patient when there's any concern for a spinal fracture, despite the fact that they probably don't do anything, except remind us that we need to worry about the spine. So this young lady, she was taken to Riverside, initially put in a room, then they talked about it a little bit, upgraded to a trauma, taken to one of the trauma bays. Ended up having a CT of her C-spine that had no fracture, but she had a subdural hematoma in the right parietal area, right where the laceration was. She had some kind of increasing confusion throughout transport. And I think that's pretty well explained by the subdural. So one question that I was left with after kind of following up on her at Riverside, nobody really investigated why she fell. So it's not clear to me if this was actually like a mechanical, tripped, fell backwards, or if this was a 90-year-old patient who had a syncopal episode. She was confused, didn't remember the episodes, her son was with her but didn't actually see her. So I think that's something important to keep in mind. Probably a 12 lead, I didn't see that one was done, but heart attacks are a common reason for 90-year-olds to have syncope and fall. So that's probably one thing that I would have done differently on the run. Because then maybe she would have been a STEMI activation instead of a trauma activation. Although she didn't have a STEMI, she had a subdural. But. Questions about this case?
So, is the difference between protecting their C-spine and them not getting as much evaluation by us not C-spine or not C-collaring them? Is that big enough of a difference for us to warrant buying like softer collars?
The softer collars seem to cause just as much discomfort.
Okay.
Yeah. I know at OSU we don't normally change the collar out, but like at Grant, the first thing is before moving the patient over, we change the collar to one of those softer collars.
Mm-hmm.
They complain about it just as much. I don't think it makes a lick of a difference.
This was actually my run, and I kind of remember it, kind of don't, but her fall was literally unwitnessed by anybody.
Yeah.
Her son had walked her out to the sidewalk, and he was thinking about getting in the car, and he forgot something. He turned around to walk back in the door, he turned around, and she was on her back. And she told us she fell straight back.
Yeah.
But she couldn't remember why she fell. She didn't know if she tripped over anything. So we went ahead, I'm pretty sure we went ahead and collared her and took her on down, but nobody knew why she fell.
The lead could have been the primary cause.
And I remember this because I was surprised they didn't make her a trauma, because when I called it in, I told them fall from standing, she hit her head, she was complaining of a little bit of neck pain, and so they put us back in room 62, and then before we had, and then the nurse came in and I told her again, she goes, oh, this should have been a trauma, and then we rolled her into the trauma room and they made her a trauma alert. But it didn't surprise me when it came back that she had a subdural, because she hit hard.
Yeah.
So.
And,
She didn't want to go to the hospital either.
I think her GCS was documented as 14, one off for some confusion and not clear speech. So decreased GCS in a geriatric fall, that's a trauma alert, that meets criteria. So I agree, it should have been a trauma initially, but how did you call it in to convey that you're concerned for that?
I didn't say a trauma alert, I just said 90-year-old female fell from standing, hit her head, complaining of neck pain.
Yeah.
And
ding, ding, ding. That's three right there.
And she was slightly confused. So
yeah.
I'm pretty sure that's what I said. It was a while ago.
Probable loss of consciousness?
I did, yeah.
That was their fault, not his.
Well, no, this is one of those that we expected to be a trauma alert when we got there, and it wasn't. And we were surprised.
Yeah, that was.
Yeah, I think calling it in like that, you can't ask for much better information than
Hello.
go back like that.
Yeah, he hit all the bases.
Yeah. All right, let's see what the next case is. All right, so this was a 67, I think this may have been your case as well. 67-year-old man, unresponsive in the front passenger seat of a car, cyanotic, breathing 6 respirations per minute, described as agonal respirations, pulse ox on room air 55%. So this guy has a tracheostomy, complicated cancer history, some sort of head and neck mass, had his larynx resected probably doesn't have any communication there. that he's near about to code and turning blue. What do you do for this guy?
Sucks.
Yeah, ABC. So airway, and you got to suction that thing out. So that's what they did. Just with suctioning, he improved significantly. What I really liked about this case was the documentation of it. You know, the approach, same as any other patient, airways, and then if that weren't working, breathing, circulation, etc. But so they documented that suction 3 times and had to dilute these thick, nasty, disgusting secretions with normal saline. Then oxygen was placed over the normal breather. And then it's very clear from the documentation that there was improvement after these interventions. So in the narrative, described as starting to breathe better, respiratory rate increased, color improved, and patient became more responsive. That sounds like, well, pretty clearly fixed the problem. And then also vital signs were recorded before and after intervention and show immense improvement as well. So I just thought that this documentation was really great, and I just wanted to point that out, that very clear documentation of intervention and the response to intervention.
This run, a little bit more history on this. The lady had taken her brother, the patient, to the doctor. And after the doctor's appointment, they'd left. He was starting to have difficulty breathing. And instead of calling 911, she drove across town to her brother's business, which happened to be LAPD, the gun shop.
Oh, I was there.
Yeah, it was that one where we pulled her out of the car.
Yeah.
And then he's the one that called 911. So there was a delay in care by her driving across town.
Good Lord.
That
You won't
explains
do
how
that
just
again.
a little mucus plugging led to those pretty nasty vital signs. But some people. So this was a 22-year-old young gentleman who had a little table saw incident. Left hand, this is a straight description, cut 2 of his fingers tips off and then fractured and caused avulsion injury to his other 2 fingers. Fingertips were in a bag in a cooler on ice. Tourniquets were initially in place, which they described further as t-shirts kind of tied around the arm. Bleeding was controlled with direct pressure, fingers were bandaged, and those t-shirts that may or may not have been doing anything were taken off. So, amputation management. First thing, this is obviously a circulation problem, but you control life-threatening bleeding. And this is like any sort of serious trauma patient. You place a tourniquet if direct pressure is failing. We're all about early tourniquets nowadays, so if there's pulsatile blood and direct pressure is not fixing it, just go ahead and put a tourniquet on. Especially for something like an extremity, like an upper extremity. In the OR, hand surgery all the time, they'll use a tourniquet for up to 4 hours with absolutely no bad outcomes. I mean, they do that every single day. So with the tourniquet, place it as close as possible to the site of bleeding so as to be causing as little ischemia as possible. And then, hey, what's up? For the amputated part, clean off any major dirt or debris. Control the bleeding on the amputated part as well, so pressure dressing on the stump so that the blood that's within there doesn't all drain out of the amputated part. And then put that in a bag, put the bag in a cooler, airtight bag in a cooler on ice. Not directly on ice, and wrap it in sterile saline soap if possible. For fingers, reimplantation is possible up to 24 hours of cold ischemia time. So if those fingers are on ice, they can be reimplanted sometime tomorrow, which I think is pretty impressive. Limbs that contain muscle, it's only 12 hours, but interesting there's worse. So I just wanted to review some basic hand anatomy because I wasn't sure from this description what the injuries actually were. So, there's the proximal, middle, and distal phalanx, the proximal interphalangeal joint, PIP, and the distal interphalangeal joint. That's really all we need to know for this. So, the x-rays showed amputations through the middle phalanx of the index finger, the middle phalanx of the middle finger, a fracture of the distal phalanx of the ring finger, and a dislocation at the distal interphalangeal joint, and a fracture of the middle phalanx of the little finger, and a dislocation there, and then some soft tissue injury to the thumb. So, Kim, I was wishing for a picture of this when I was reading this, because that seems like a pretty gruesome injury.
So when it gets amputated right through the middle of a phalange, do they take that whole phalange out and then reattach the rest of the finger, or do they try to put the two bones back, put the bones back together?
Finger reimplantations are very surgeon-specific and patient-specific. There's really no agreed-upon approach. Anything distal to the distal interphalangeal joint, nobody tries to reattach. They just close that, and sometimes they'll remove bone if it's sticking out so that they can close finger, or they'll just let it close by secondary healing. Proximal to the proximal interphalangeal, most people will reattach. Between those two in the middle phalanx, there's really no standard approach. This young man did not have either reattached, so he had some bone pulled out, plucked out from the middle phalanx in both his index and middle finger, and then it was closed directly in the OR. And then his right finger, he had his extensor tendon repaired on that side. The distal joint fused, so he would not have mobility in that distal joint in his ring finger anymore. And then the middle phalanx of his little finger was fixed, and then he just had some skin grafting done to the thumb.
Was he treated at OSU or Riverside?
Riverside.
Just as a reminder, we've taken reattached fingers and hands and such to Riverside for so many years. Everybody always thinks that they're the only ones that do it. OSU has been reattaching fingers now and doing microsurgery for a while, so you can take them to both places. They're basically having the same surgeons. They're trading them back and forth every other year.
Dr. Cook's at Riverside, it's me taking care of Riverside.
Why is that?
He's asking you a question.
Why is that?
Why is that? Because of his reputation.
Which one?
Dr. Cook.
Oh, fair. Okay. Next one was a gunshot wound to the chest.
That's yours, Nico?
Patient found in the middle of the street. Described as 3 wounds, left chest, left posterior shoulder, and a graze on the cheek. Sounds from the description like he was very stable, wounds were bandaged, transported, had equal breath sounds. He was taken to OSU as approaching, started to have some shortness of breath that he was complaining of, but it's well documented that still had equal breath sounds. So didn't get a needle put in his chest or anything like that. Anything else you want to say about kind of the case?
They did the x-ray and he did not pneumo. They said that it was 2 centimeters above his private artery.
Yeah. So I tried to get the images pulled into this, and with our new imaging software, I was not able to figure out how to actually get the images out and into this presentation. But it was pretty unimpressive imaging because there is no pneumothorax. He went close enough or through partially the clavicle and he fractured his clavicle, but through and through without hitting anything else major.
I thought it was really weird because I thought he was on something because his heart rate would not go above 46.
Oh
Blood
yeah.
pressure was like 150 already. But
Yeah,
he
that was
claimed that
interesting.
claimed that he got jumped while he was minding his own business.
Always.
Uh-huh.
And, yeah.
That's why the
If
police
you were
were
jumped minding your own business, your heart rate's gonna be 160.
This is the guy that drove from Weber Road to
Yeah.
Stonehenge up here.
Yeah. Yeah, he drove after he was shot.
Oh yeah, flood the
Drove
scene
home.
first. Yeah, good.
And Stonehenge Apartments.
So I thought that was interesting, and it's not really well addressed. And I looked through his hospital course. He stays bradycardic, but nobody does anything about it. So
When I was over at Grant, they were talking about these patients that hemorrhage and get like a bradycardia, that it's considered like a protective response because it keeps you from bleeding out more.
interesting. Usually in these
Like
trauma patients, I see the
evolutionary
bradycardia right
response.
before the arrest. Which I was reading this and I was like, oh, so then his breath sounds were still equal, but he was bradycardic, and then you took him to OSU, and I was like, oh, and then he arrested and died. But that's not how the case went. He had no injuries there in the left side of his chest.
Yeah, he's pretty lucky.
Yeah, somehow.
Do you guys do chest x-ray before you do chest tubes and trauma like that?
No. So for him, if he had decreased breath sounds, was unstable in any way, he would have gotten a chest tube right away. He had equal breath sounds. This wound was kind of high on the chest, and he was hemodynamically stable, so they waited for the chest x-ray. He ended up not getting a chest tube, luckily, because there was nothing in his chest. Now, if you had needled him as you were approaching, with him having shortness of breath, which I think also would have been a perfectly fine approach, then he would have gotten a chest tube right away. Because then he would have a pneumothorax, whether it was from the bullet or the needle.
We would give
So
We appreciate procedures.
the only thing was that fractured clavicle. He had some local wound care, orthopedics was consulted, washed it out a little bit, put a bandage on, discharged. He had follow-up with ortho, so this was about 2 weeks ago. He had follow-up on Friday. They repeated some x-rays, looks fine, he's gonna be in a sling for 4 more weeks. And continue to be in jail for 4 more weeks.
He went to jail.
He did go to jail.
Mind his own
This
business.
is weird, he's minding his own business.
Minded his own business. I
Yeah.
It's a punishment for people that
You
get
got-
shot at the
This
over.
ain't
He's a liar.
He got jumped
He's
by
a
two
liar.
dudes, 2 dudes with masks, he said.
Liar.
Couldn't describe height, weight. And then all of a sudden it changed to 3 dudes on the way to hospital.
Except for the names, he just didn't know their names.
Oh, no, never met him before. So I feel like we can't finish without having a chest pain at least once a month. So this is a 69-year-old gentleman who had acute onset, 10 out of 10, mid-sternal chest pressure. He was sitting, this happened right after he was in a really heated argument with somebody. And there was no radiation of the chest pain, he felt nauseated but did not vomit.
This guy was fucking with his wife pretty sad.
That's what we mean by heated argument. He got divorced immediately prior to this, just didn't know it.
What happened?
He was arguing with a friend.
Um,
Yeah, not a friend anymore.
Oh,
She gave him the eye.
I don't remember who he was fighting with. He looked
Some
drunk.
So there's 4 specific historical risk factors that have been shown to increase the likelihood that somebody's having a heart attack. So I wanted to mention these. So one is exertional symptoms. The chest pain starts with exertion, or exertion is making the chest pain worse. Associated vomiting with this, not nausea, but actual vomiting. Associated diaphoresis, and radiation either into the right shoulder, the neck, or both shoulders, but not just the left shoulder or left arm. So this gentleman received aspirin, nitro, oxygen, fentanyl, Zofran. He had a heart attack. So I want to go through his EKGs because they're really fascinating. And you guys did like 12 EKGs in the 6 minutes it took to get to the hospital. So this is really cool. So here, obviously, this EKG is concerning for the STEMI right here in the anteroseptal leads. No real depressions anywhere else. He's got a couple PVCs, which is interesting. And then this, so that was at, let's see here, 2:30. This was 2:33. No more STEMI. Now it looks like he's got an inferior STEMI.
Wait to go into VTAC.
Yep, he's ready. He's ready. He's trying to get that PVC to hit right on the T-wave and go right into VTAC. Working on it. And laterally here, he's definitely got some injury pattern, and maybe he's having a STEMI over here too.
It's not a J-wave anymore.
No, definitely not early repull at this point. And so that's 2:33. 2:35, 2 minutes later, ooh, now we're really getting something going on here. Oh, and another PVC here. And his injury pattern here has changed significantly. His QRS has widened.
Yeah, put
It's
on the siren,
tachycardic.
boys.
This is now another 4 minutes later. So still have this injury pattern here, have a definite wide QRS and a right bundle branch block here, and a left anterior fascicular block.
Did you guys go straight to the cath lab?
Yes. And then this is another 3 minutes later. And now, 3 minutes later, we're back to an anteroseptal STEMI. Tachycardic and a narrow QRS again. So this was over the course of 12 minutes and all of these different EKGs.
That's why we kept shooting them, because they were all over the place.
Yeah.
I mean, they were very bizarre.
That's an
Did you have
irritable
to
heart,
take it,
man.
or
I'm
was-
surprised you
was
didn't.
the life pack doing it itself?
No,
Because
I
whenever
was-
there's a change, the life
Yeah, I
pack
was doing-
should do another 12
Yeah,
hours.
I think Life
Oh,
Pack
really?
did probably like 4 of them, but the other ones I was the one pressing. You could see.
Yeah, whenever there's a change
Each
in the
one was
life pack,
different.
it does another 12 when you're still hooked up.
Yeah, I know.
Oh, that's
It
cool.
automatically spits it up.
It did about 4 of them on its
Yeah,
own.
that's an irritable heart, man. I'm surprised he didn't go to VTAC.
He did on the table.
Did he?
Yeah.
Oh
Yeah,
man,
the
let's
rest
just
of
keep
them,
going.
yeah.
So any specific concerns for a septal, an anteroseptal STEMI?
Yes.
Yeah, I mean, you're talking about them.
Yeah.
All of this crazy, these fascicular blocks that are happening, this right bundle branch block, I mean, your whole electrical system goes right down the septum. So having an acute MI there becomes an incredibly unstable heart and very likely to go into an arrhythmia. So he went into a VFib arrest on arrival to the cath lab. Ended up getting return to circulation. This is your EKG right here, your first one. And got shocked, whatever. Pulses came back, they did a cath, and this is what the LAD is supposed to look like. And this is where his stopped. So that would be the issue. Had a balloon, a stent put in. He got put on a balloon pump. So the balloon that stays in the aorta and assists with cardiac output, and he was on that for about 24 hours. But after, and went into VTAP multiple times afterwards as well, but self-resolved. And he got discharged less than a week later. So from your saying hello and shaking his hand to his balloon was 39 minutes. You can't ask for much better than that. 6 minutes on scene, 18-minute car ride, and 15 minutes of restarting his heart before doing a heart cath and getting a balloon through that lesion. Pretty impressive outcome.
Nick, was this the one that Dr. Run was with you?
Yes.
Okay, so this run, the cardiologist is actually coming here he's got the entire thing, Dr. Run's got the entire thing on disc. The cardiologist actually wants to come in and talk to the department on this run. He thought it was that well done. And so he is sometime next month probably going to come back and we'll see this again.
You know which cardiologist?
If you'll notice all those.
I can't remember. I've got it written down, but
I can print those off.
I'll let you know.
This run was a perfect example of what further cements like Ohio State being the place to go, because literally he would have arrested in the ER at Riverside because they stopped us in the ER.
So they stop all?
They pretty much stop every single
It's
one.
very rare that we get a chance to go straight to him.
And so this was a perfect example, because as soon as they put him on the table, he arrested.
Yeah, because I know we've talked about that before too, that with the STEMIs, you guys are often bypassing Riverside and going.
Wait.
And medic 101 unconscious person, so that's 1030, 500. Medic 101 unconscious person.
But you
This
can
is
run across
Do
the street
we
faster.
put you on the scene?
This was one last bonus case that I saw the other day that I thought was well related. So this was a 55-year-old gentleman complaining of some epigastric pain, nausea, vomiting. He walked into the ED. He was, quote, recently hospitalized for the same and was just put in the waiting room for about 2 hours and then finally taken back to a room. No lab work done, no EKG done, nothing in triage. But during that hospitalization for the same thing, he had had a heart cath and had 2 stents put in. And so this was his EKG. And sorry, this is a picture I took on my phone and then sent to the cardiologist. But he also is having a anteroseptal STEMI. And then he's also got this little bit of lateral STEMI here as well. And then obviously these deep ST depressions. The only issue was his EKG from just 6 days earlier looked almost the same with these elevations and these depressions and this little bit of elevation here. So I wasn't sure initially whether to just call a STEMI for this guy because, I mean, so he wasn't complaining of any chest pain, just some epigastric pain, actively vomiting and diaphoretic. So vomiting, diaphoretic, those are the 2 of the 4 risk factors, 2 of the 4 factors that increase the likelihood of an MI. And he just had a stent put in 6 days ago. And so he told me that he was taking all of his antiplatelet medications appropriately, but didn't seem like a very reliable person.
So this EKG was when he had the stent put in?
This was pre-stent.
Pre-stent, and
then this is right
now
now.
6 days later.
Yeah.
Is all that depression from stent placement or is it new?
So it turns out this is all new/recurrent from in-stent thrombosis. So he had not been taking his medications, his antiplatelets, since discharge, and 5 days later he had in-stent thrombosis of both stents. And so he had one in his LAD, one stent in his LAD, and one in the obtuse marginal coming off the circumflex.
Did you guys cath him again?
Yeah, I ended up calling the cardiologist, talking to him, texting him these pictures, and describing to him what was going on. He said, God damn it, I have to come in at 4 in the morning. And so we called a STEMI.
Because the guy decided not to take his
So basically, he's
medication.
non-compliant, know, you can give them the prescription, you can't make them take it,
Yeah,
but.
yeah, lead a horse to water.
That's called a death wish.
Yeah, so.
2 hours before drinking milk.
Questions, comments?
To wait.
We went kind of fast, we probably could have fit in a few more, but
Those were good.
I don't know
Yeah,
how
those are good calls.
contentious it is.
Kind of across the board too. So.
Yeah, good variety. All right.
Cool, thank you very much.
Yeah,
Thank you.
Appreciate it.